factors 2, 7, 9, and 10. So this means we will not be able to measure coumarin levels as we would like to measure low molecular weight heparin levels, but that what we could measure is the activity of clotting factors, and that means, in terms of planning patients for surgery, the effect of coumarin's vitamin K antagonist mainly depends on the duration or on the half-life of the inhibited clotting factors. And as we have 4 clotting factors being not sufficiently produced with the use of coumarins, we have to look at the half-lives, and the shortest half-life has the factor 7, that is 1.5 to 6 hours, but the longest half-life has the prothrombin, factor 2, that ranges up to 48 to 60 hours. And this explains why it takes at least 2 to 3 days after cessation, for example, of warfarin, until the coagulation system has returned to normal. And this is, in comparison, what we know from the NOACs, or the low molecular weight heparins. You can measure coumarins, the plasma half-life of coumarins, but it doesn't say anything on the anticoagulant status of the patient. And compared to the NOACs that you can measure is a very typical feature of plasma levels, with a peak level and with a trough level, and after the trough level the next intake of the drug is scheduled, and then you have a peak level and a trough level again. So we have a completely different pharmacokinetic between coumarins, vitamin K antagonists, and NOACs and low molecular weight heparins. And indeed, the plasma levels and the course in healthy volunteers, in patients without any kind of renal dysfunction, is quite similar between the drugs. And this is a comparison between rivaroxaban and enoxaparin. That what you see here is a very fast onset with plasma peak levels ranging around 3 to 4 hours, and roughly 1 day after the intake, the drug is almost completely excreted, and this applies to both drugs. So the approval status of most NOACs in Germany, and I think this is also true for Europe as well, is that we have on the one hand side a thromboprophylaxis approval for patients undergoing hip or knee surgery, replacement surgery. Then we have the more medical approvals, licensures in the prevention of stroke or non-valvular atrial fibrillation. And third, we have the indication for the therapy or secondary prophylaxis of deep vein thrombosis and pulmonary embolism. Only at the moment, only for rivaroxaban, we have another indication, another approval with a very fairly low dose of 2 times 2.5 milligram for patients having acute coronary syndrome, and those patients would take the drug in combination with a dual antiplatelet treatment. So edoxaban, that has come over from Southeast Asia, that has gone another way. It has in Europe the approval for the prevention of stroke in AFib patients, and also for the therapy and secondary prophylaxis in DVT and pulmonary embolism patients. So I will now go on, and this is made due to 4 studies, 4 approval studies that are summarized here in terms of were they better to reduce stroke or systemic embolism compared to warfarin. And that what you see here, this is for the different drugs. This is for Pradaxa, this is for rivaroxaban, this is for apixaban, and this is the data for edoxaban. You see that all the drugs were either better, significantly better, like the apixaban or the dabigatran in the prevention of stroke, or they were not inferior compared to warfarin, which was true for rivaroxaban and edoxaban. So that was the basis for the approval status in Europe, and I think also worldwide, that we have for the NOACs so far. Now, what do we do in patients who are on NOACs and present to the anesthesia assessment clinic? What do we tell the patients? Usually in the anesthesia assessment clinic, we try to get an idea of what are patients' specific risks in terms of bleeding history or a thromboembolic history. We also try to get an idea of what is the thromboembolic risk of surgery. Is there a certain risk associated with that surgery the patient is scheduled? And in addition, we also have to take into account if a patient is on anticoagulants, is there a specific risk of bleeding that comes with the surgery? And in addition to all these 3 points, we also have to have some information on the specific risks that comes with the anticoagulants, and this means that we have to have some idea what are basic pharmacokinetics that are true for these drugs. And this will be very basic, this will be very easy for you to understand, especially to understand that all these 4 NOACs that we have on the market are not that much quite different. So let's start with the thrombin inhibitor, the Pradaxa. The generic name is dabigatran. I would like to highlight that the onset of action is very fast. After 3 hours, you have peak levels. The half-life ranges between 12 in healthy patients up to 17 hours in patients with renal impairment. And the elimination, and that is a very important characteristic of this drug, is mainly done by the kidneys. More than 80% of the drugs are excreted, almost unmetabolized via the kidneys. So what is the basic pharmacology for the factor Xa inhibitors? And in comparison, the peak levels are reached very fast as well. Between 1 and 3 hours, all of the NOACs have their peak levels, so they act very fast compared to vitamin K antagonists. The half-life is also quite comparable to the thrombin inhibitor, ranging from 5 to, let's say, 14 hours. And as a rule of thumb, you should have, or keep in mind that 10 to 12 hours is the half-life of most of these drugs. And that means at least after 2 to 3 half-lives, we will have approximately between 10 and 25% of plasma levels remaining in the blood. So if you look at the line with the elimination mode, that's what you see here. And I would like to conclude is that all drugs to some extent are excreted by the kidneys. So also for the factor Xa inhibitors, renal dysfunction, renal failure plays a role, and these patients are definitely patients which have a risk to accumulate this drug and may therefore, in terms of surgery and in the perioperative setting, have some risk of bleeding, and you should take into account when you schedule these patients for the surgical procedure. Does lab testing help? And this table is a bit confusing, but I will guide you through this. But first of all, I want you to understand that the more arrows you see in a field, the more sensitive the assay in the line is to the specific drugs which are in in the title line here. That says the APTT is quite sensitive to dabigatran, but it's not very sensitive to apixaban or edoxaban, while PT ratio seems to be more sensitive to rivaroxaban than to dabigatran or the other two factor Xa inhibitors. The most sensitive test to measure dabigatran is the regular normal thrombin time. That is extremely sensitive, but if you want to measure plasma levels of dabigatran, you have to use the diluted thrombin time, and one of the available assays is the hemoclot. If you want to measure rivaroxaban or other factor Xa inhibitor levels, you have to use the anti-10A activity, or even more specialized, a calibrated anti-10A activity to definitely know what is the level. Is the level prophylactic or still therapeutic of the 10A inhibitors? So it's not that easy with the standard coagulation lab that we normally use for the assessment of the coagulation system in the preoperative setting with NOACs. So I would like to conclude we do not have a very reliable correlation of the standard lab tests like APTT and PT or PT ratio with plasma levels of NOACs. The standard lab just shows you with the APTT if this is elevated in dabigatran patients that the drug is on board, but it does not correlate very well with certain plasma levels. And for the 10A inhibitors, the anti-factor Xa activity measures plasma levels, but unfortunately they do all just say if the drug levels is prophylactic or therapeutic or below prophylactic, but it does not correlate very well with the anticoagulant effect or even with the risk of bleeding. So we are still waiting for some tests to properly and reliably show a good correlation between NOACs plasma levels and the results of the lab testing. So does bridging play a role for the NOACs? And this is just one study that was done in patients treated with dabigatran. It's a sub-analysis from the approval study, and they looked at patients who were treated with dabigatran, which is in the two columns here on the right-hand side, and observed patients who were bridged with a low molecular weight heparin and compared them to patients who were not bridged preoperatively, and assessed either the bleeding rate and the rate of stroke and systemic embolism. And let's start with the bleeding rate. That's what you see here for the dabigatran patients. The bridged patients had an incidence of 6.5% versus 1.8% in the non-bridged patients. That was a 3.67 increase in the risk of bleeding. That was highly significant, indicating that there is no favor for the bridged patients in terms of the risk of bleeding. And do these patients pay this with a higher risk of stroke and systemic embolism? The result is here. There was a very small incidence of 0.5 in the bridged patients and 0.3 in the non-bridged patients. That was a non-significant difference. So from these group of patients, and the patients included were mainly undergoing minor procedures, these data say that for minor surgery without bleeding risk, there is probably, it is not recommended to bridge these patients, and most of these patients were AFib patients and treated with dabigatran. So bridging seems to be a different issue for the NOACs compared to the warfarins. And so how can you do it when you have the patient in your pre-assessment clinic? And first of all, I would like to discuss the setting of a relatively healthy patient with a normal renal function, and the surgery brings a low risk of bleeding. And usually, in most of these drugs, with a normal renal function, you should have excreted the drug almost to the majority from the blood, so that stopping the drug 1 day preoperatively, 24 hours before the surgery, would be sufficient to prepare the patient for surgery. Then surgery is performed, and you will start the drug with the first dose after surgery on the first day after surgery, not on the day of surgery, but on the first day of surgery, after surgery. So this is fairly easy. The more complicated situation is with patients who have reduced renal function or who have an increased risk of bleeding, either due to surgery or due to other reasons. And in these patients, it may be necessary to stop the drug, the NOAC dose, up to 4 or 5 days prior to surgery, depending on the renal function, on the type of surgery, and on the substance, especially for the production of the thrombin inhibitor that is mainly to 80% excreted by the kidneys. If you have an impairment of renal function, it is recommended to stop the drug at least 4 to 5 days before these patients undergo surgery. And have in mind, up to now, there is no bridging preoperatively recommended for these patients. Then, for the other drugs, the factor Xa inhibitors, in most patients, although also those with renal impairment, a cessation period of 2 to 3 days will be sufficient to have a normalization of the coagulation system so that the patients are well prepared for surgery. Then you bring them to surgery, and what you do is, after the surgery, is that you do what you know to do from your history. It may be necessary, if there is still a risk of bleeding from drainages from the operation site, to switch to a low molecular weight heparin. This is also true for patients who have an indwelling epidural catheter for post-operative pain therapy. Switch them to that, what you know to do, switch them to a low molecular weight or to an unfractionated heparin. And once the epidural is removed or the bleeding risk has settled, then you can start the first dose of the NOACs. That can be on the second post-operative day, that can be on the third or fifth post-operative day. So post-operatively, it seems to make sense in some sort of or type of risk patients to switch these patients to another anticoagulant before you start the NOACs again. So, and this is especially, and this is just one slide for those colleagues amongst you who are anesthesiologists. This is from a German guideline highlighting the period of cessation before epidural punction or before you remove the catheter. And these data say that for dabigatran, you should stop the drug, as I explained before, roughly between 60 to 80 hours, almost 3 to 4 days. And this is also a bit shorter in rivaroxaban. This is roughly 2 days, a bit more if you want to be very sure and secure and safe, then you wait at least 2 days. And for the apixaban and the edoxaban, you should wait 72, 75 hours. That is approximately 3 days before you place an epidural catheter or before you subject this patient to a greater or major surgery. So, and the rationale behind this recommendation from this German guideline is that if patients are treated with a therapeutic dose of the NOACs, a cessation of 5 half-lives is recommended to have the plasma levels reduced as much as possible before patients are undergoing surgery. And also have in mind, so far there is no pre-operative imaging recommended. So, and again, in epidurals or in patients who have a greater risk of bleeding, switch these patients to a low molecular weight heparin until the bleeding risk has come down, and then you can switch them back to the NOACs. So, and this will be the last part of my talk, what affects the management of NOAC-induced bleeding. And we are seeing more and more patients in our hospital with NOAC-induced bleeding. What do we do with those patients? First of all, I would like you to know that this was investigated in the approval studies as well. This is, again, the meta-analysis from Dr. Raft from the US, saying that in the pooled analysis of all the patients included, roughly 60,000 patients, the NOACs were doing better in terms of bleeding risk compared to the warfarin-treated patients. There was definitely some difference between the drugs, but due to the fact that different bleeding definitions have been used in other approval studies, those data cannot suggest that the drugs are comparable with the other ones, but that what we can take from this slide and from this analysis is that probably the risk of bleeding is lower than that for warfarin. And what is the situation with the real-life intake of NOACs compared to warfarin? And this is also data concerning the major bleeding incidents. And here you see comparisons between warfarin, which is always given in blue, and some NOACs here, the apixaban and the dabigatran and the rivaroxaban. And then what you see is that the drugs are doing much better. You have a lower incidence of bleeding compared to warfarin, and the rivaroxaban is also not doing worse, but there was no significant reduction with the use of rivaroxaban in terms of bleeding. So a good perspective for the future, to my understanding, with the NOACs, we probably will see a lower incidence of gastrointestinal and also, I hope, intracranial bleeding in patients requiring anticoagulant treatment. So what do you do with a patient who is mildly bleeding, who is stable, who does not need transfusions? Stop the medication, put this patient on an IMCU or an ICU, observe this patient and wait. Do nothing. Do nothing, because the kidneys are your best player in the team. They will excrete the drug, and at least I would say 48 to 72 hours later, the body will have removed the drug, and the patient will be out of the risk of significant bleeding. If you have a moderate to severe bleeding in these patients, the patients get unstable, they require transfusion. Try to consider charcoal if the intake has been 1 to 2 hours before hospital admission, then charcoal makes sense. Try to apply mechanical compression where it is possible. Surgical hemostasis may be treated, support hemostasis, transfuse the patients to keep the hemoglobin and the oxygen transport stable, and especially for hemodialysis, it may be an option in some patients, but only in some patients, to dialyze the dabigatran due to its low protein binding. It can be dialyzed. This is not true for the factor Xa inhibitors who have a fairly high protein binding of 8 85 to 95%, but the dabigatran has a protein binding of 32%. And this is shown by this trial in hemodialysis patients who were treated with the dabigatran. You can reduce with a 4-hour session of dialysis the dabigatran levels by roughly 50%. And this is apparently independent of the blood flow of the hemodialysis machine. So in stable patients, there is an option for hemodialysis to excrete the dabigatran. But if the patient is not that stable to take and to stand a hemodialysis, what to do then in life-threatening bleeding? And this is definitely the case for special hemostasis management. And I would like to give you some data on the use of PCC, prothrombin complex concentrate, and the specific antidotes that we have on the market or that are under clinical evaluation. Just one word is to fiber-activated factor concentrate or a NOAC. They are possible. There are some in vitro data that I will not show here. So what is the case with the prothrombin complex concentrate? There is healthy volunteers. They were placed and started on edoxaban. Before they were started on edoxaban, it was measured how much they will bleed from a punch biopsy of the thigh. And they measured the bleeding duration and the volume that is given here in these two cartoons. This is the bleeding duration, this is the bleeding volume, and the dotted line is that what the volunteers bled without being on edoxaban and how long it took to take the edoxaban, and 2 hours later they were treated with escalating doses of the 4-factor PCC. Escalating doses starting from 10 up to 50 units per kg, and that what you see here is compared to placebo, what is the dark gray column, that the 4-factor PCC at a dose of 50 international units per kg reduced the bleeding duration and also the bleeding volume below that what were healthy volunteers. So these data indicate that there is at least some effect of PCC at a fairly high dose of 50 units per kg to reverse or to limit the anticoagulant effect of edoxaban. And the other good news from this study is that in these healthy volunteers, no thromboembolic have been observed. What about the antidotes? And this is definitely the great issue at the moment. We have one antidote, a specific antidote approved in Europe and worldwide, that is idacizumab for the Pradaxa, and we have 2 more direct antidotes, which are no antibodies, but direct antidotes, which are under clinical evaluation that I will introduce you in a couple of minutes. First of all, the idacizumab, and the brand name is PreAssessment, is a specific antidote, a monoclonal antibody fragment against the Pradaxa, and this was studied in 90 patients, either suffering from a severe bleeding or scheduled and needing emergency surgery for a disease other than bleeding. These patients were were included and received 2 short infusions of idacizumab, and that what you see here is the thrombin time. That was the thrombin time that was elevated prior to the drug infusion, and here that what you see is that the thrombin time was below normal for roughly 24 hours after the infusion. This was also due for the patients undergoing emergency surgery. So roughly after 30 minutes, the thrombin time, so the effect of the plasma levels of dabigatran were reduced to normal, and the efficacy rate was between 93 and 98% in the treated patients. This drug has been approved on the European market and is available. And to my understanding and to my experience, we have treated a couple of those patients. It is really effective in reducing the anticoagulant effect of Pradaxa. Now we have a specific factor Xa inhibitor called andexanet alpha. This drug is now in a worldwide study under clinical evaluation. It is no antibody fragment, but it is a recombinant protein that is quite similar from its structure to factor Xa. It binds the factor Xa inhibitor and inactivates the anticoagulant effect. Therefore, it reverses the effects of NOACs, and not only NOACs, but also heparins, low molecular weight heparins, and fondaparinux. It has a very short half-life, so that it may require a continuous infusion if patients are treated with oral factor Xa inhibitors. But so far we do not have any data on the thrombogenicity, so the safety side of the drug. But we have some clinical data from a preliminary study involving 67 patients who were bleeding either due to apixaban or rivaroxaban intake. And they were started with a bolus of 480 or 400 milligrams, and then a continuous infusion of 2 hours was commenced. And here you see the results. The results are given as anti-factor Xa activity. This is the baseline for both drugs, either rivaroxaban or apixaban. This is the anti-Xa activity at the end of the bolus and at the end of the infusion, and after the infusion has been stopped, the anti-factor Xa levels rise again, showing that there is still some remaining activity of the drug. But as proof of principle, the drug has shown that it can reduce almost to normal the anti-factor Xa levels in the rivaroxaban, and even to a greater extent to the apixaban treated patients. And from a clinical point of view, the involved physicians have said that roughly 80% of the patients who were treated showed good or excellent hemostasis after the application of andexanet alpha. So what about the third drug that is under evaluation? This is a drug called siraparantag. This is a molecule that binds to factor Xa and to factor 2A inhibitors, and both activates them. It has been shown in an animal model that it reduces bleeding, but it seems to be a smaller problem to monitor the effect, as the APTT, the anti-10A activity, and the prothrombin time were not influenced by the infusion of these drugs, but only the whole blood clotting time showed some reliable results and correlate very well with the effect of the drug. And this drug was tested in healthy volunteers. Again, those healthy volunteers, they were started on 60 milligram of edoxaban. That is a therapeutic dose of edoxaban, as the other trial with the PCC concentrate as well. And that what you see here, there is a dose escalation from 25 milligrams to 300 milligrams. And that what you see here is the brown line, that the whole blood clotting time after the infusion of serum parantarac has been almost reduced to near normal levels in these healthy volunteers, and this was even more pronounced with a higher dose than with a smaller dose, for example given the 25 milligram dose. So if this drug is going on in the clinical evaluation process, we may have in the future a drug that can inactivate factor Xa inhibitors and thrombin inhibitors, and this may be very valuable in situations where the patient cannot say which drug he has taken, and therefore I'm very keen looking to this drug if this drug will make it to the market. So, in conclusion, for the management of bleedings with NOACs, and this is my last slide, for mild bleedings, please wait. Waiting is an option. Observe the patient and do nothing. The kidneys will eliminate the drug. In severe bleedings with NOACs, first of all, we should assess the last intake, the renal function of the patient. We have to know what is the type of the NOAC, and we have to know what dosage the patient has taken when for the last time. And then, as more general measures, support hemostasis, keep the patient stable, prevent secondary organ failure, especially stimulate diuresis, keep the kidneys going. And as a reversal antidote treatment, this is indicated in life-threatening bleeding. That is, for me, example given intracranial bleeds or profuse bleeding from wounds or trauma sites. And for dabigatran, we have a very effective monoclonal antibody fragment as a direct antidote available. This will reduce the bleeding very efficiently within 30 minutes of time. For the factor 10A inhibitors, so far we have no specific antidotes available. They are not yet approved, and for these patients, the use of PCC, as shown in the one study with the edoxaban-treated volunteers, a dose of 50 units per kg, may reduce the extent of bleeding. And with this having said, I'm at the end of my presentation, and I'm happy to take this. Thank you very much.
So, thank you very much, Christian. This was actually an excellent overview on a very complex issue. And we have now about 20 minutes for questions. And actually, I must remind to all the participants they can ask questions using the appropriate box in their screen. We actually have 3 questions that I will forward you, of course. And the first one is at the beginning of your presentation, so you probably addressed this later on, but actually the question is what to do if we want to do a regional analgesia, we want to place an epidural catheter, and we have patients that are on this kind of drug, specifically the participant is asking about Xarelto. I think you already said something on this, but maybe you can focus a little bit more on this.
Okay. Well, I think that placing an epidural catheter is quite a risky procedure in patients treated with the rivaroxaban. So these patients have to be prepared for the placement of the epidural catheter, and this means I would have rivaroxaban levels below prophylactic levels, and this will require, depending on the renal function of the patients, to have the rivaroxaban stopped at least 48, better 72 hours prior to the surgery. Yeah, that's mainly what I would do, especially if the patient is having renal failure, a lowered glomerular filtration rate, then it makes sense to measure plasma levels to be sure and safe that the patient has no remaining drug on board. This would be my recommendation. We are very reluctant in placing epidural catheters in these patients, and we try to have the drug stopped at least 3 days prior to surgery.
Okay, thanks. I think this will satisfy the participant who asked this. And we have a second question that is, do we have any room available for plasmapheresis? If we have a bleeding patient that is actually under the effect of these drugs.
So far, I don't know any data for plasmapheresis in NOAC-induced bleeding, but I would assume that plasmapheresis should be effective in reducing plasma levels, especially for the dabigatran. If we can really detach the factor Xa inhibitors from the proteins they are bound to, I do not know. That would be speculation to say that. And so I don't have any data on this. I cannot make any recommendation for plasmapheresis. For dabigatran, the thrombin inhibitor, I'm almost sure that it should work from a principle of plasmapheresis. It should work, but it will probably not work in factor Xa inhibitors.
Perfect. So we have another question now that is indirectly related to the topic of your presentation. Basically, this participant is asking you, do we have any data about the possible use of andexanet alpha if we have an emergency cardiac surgery patient which is under low molecular weight heparin? Maybe it could be an acute coronary syndrome patient receiving low molecular weight heparin now, so we have to emergently operate him. So do we have any possibility to reverse the effect of low molecular weight heparin by using andexanet alpha in this case?
Well, there are only very limited data from the preliminary study that has been published with the New England Journal of Medicine that I've shown to you. That it was a very small study involving 60 sessions, but I think 3 of them or 4 of those patients were treated with enoxaparin, and they responded quite well to the applied dose of andexanet alpha. The success rate was not as high as with apixaban, but it was comparable to apixaban. That may say that that the andexanet alpha will be effective in enoxaparin or other low molecular weight heparins as well, but we definitely need some more data on the appropriate dose of andexanet alpha to stop the effect of the low molecular weight heparin. We have also seen, if I try to go back in my presentation, maybe I hope that everybody can see this. There is some heterogeneity between the effect of andexanet alpha on rivaroxaban treated patients and apixaban treated patients, as the anti-10A activity in the apixaban treated patients seemed to be smaller after the end of the bolus and after the end of the infusion compared to the rivaroxaban. There is a much higher scattering of the values after the end of the bolus and end of the infusion. This may indicate that we may need a higher dose of andexanet alpha to reduce the anti-factor Xa activity induced by rivaroxaban compared to apixaban. So, saying that andexanet alpha will probably be effective in low molecular weight heparins and the 10A inhibitors, but the specific substances may need specific dosages of the antidote to be sufficiently inhibited or reversed.
So Dr. Papatanasiou is asking us, you have a patient with a severe bleeding, and how much time do you think how much time after the last intake do you consider to be adequate for not taking any extra measure? It probably depends on which kind of drug and renal function.
Yeah, You're completely right. I would say if the patient is stable, if he is not bleeding, if he is not requiring catecholamines, if he's not requiring any kind of transfusion, I would say there is no reason in treating these patients with a reversal agent. Observe this patient, try to keep the kidneys going, and they will eliminate the drug. But if the patient is showing any sign of bleeding, then you can start even with peak plasma levels of the NOAC to give the reversal agent. It may influence the dose of the reversal agent if you treat the patient with a very high plasma level compared to a rather low plasma level. But I think there is no in the bleeding patient, you shouldn't lose any time to give the reversal agent when it is available to your hospital.
Thank you, Christian. Here we have a very interesting question. That is, suppose that we have a patient that is under the bigatron and he is suffering from life-threatening bleeding, and we don't have the specific antidote. What's the role of PCC here? Do we have any evidence that PCC is helping us?
Well, PCC in the case of the bigatron treated patients has been investigated in animal as well as in vitro models, and that what we know is that PCC seems to be effective in terms of normalizing or almost normalizing coagulation parameters in the dabigatran treated patients, but it also seemed to reduce the bleeding volume in the animal models. So I would suggest if you do not have the PreAssessment available in that hospital, it is better to treat this patient with a higher dose of PCC, and higher would mean 50 units per kg. That was investigated in the animal models as well, and rather than doing nothing or giving fresh frozen plasma, which will definitely be not effective.
Well, thank you again, because here you are answering even the question of another participant that is asking us how efficacious would be fresh frozen plasma if you are in a setting with limited resources. So I think you already replied that fresh frozen plasma is actually not
to my understanding, you will need liters and liters of fresh frozen plasma.
Okay, and now again another interesting question. Do we have to do thrombin time, or probably better would be diluted thrombin time, in all the patients that are under the bigatron that are scheduled for major surgery?
So far, I would not support this view. It depends very much on the risk of the patient and the risk of surgery. We would do a diluted thrombin time in patients that are, example given, undergoing major abdominal surgery, like tumor oncological surgery or intracranial surgery. In these patients, I would like to know preoperatively that there is no more anticoagulant on board. But we would do it only in these patients who have a high risk of bleeding, but I would not do this in patients undergoing laparoscopic cholecystectomy or something like that, which conveys a rather small risk of bleeding. So it's not indicated in all patients to do a diluted thrombin time when they are treated with dabigatran. Only certain patients at risk.
And Dr. Angelotti is asking you, is there any role for viscoelastic test in the assessment of a bleeding patient? Or maybe I would add, we have a patient under direct oral anticoagulants, and we want to know whether or not is getting rid of the effects.
Yeah, well, that what the viscoelastic tests will show you is that you will see some prolongation of the clotting time. It will show you that the drug is on board, but nothing more. You cannot correlate the results with the plasma levels. We have done some research in this field, and we have tested a new assay for the thromboelastometry device, and this assay is based on ecarine, and it measures the bigatran levels, and our results show that there is a very good correlation between the results of this new assay and the plasma levels that we have measured with the hemoclot. So, saying that if this assay will make it to the market and will be marketed, then we will have a point-of-care based thromboelastometry assay to measure the effect and the plasma levels of dabigatran at the bedside of the patients. For the factor Xa inhibitors, it is a bit more complex, and at the moment there is no reliable point-of-care measurement and assay for these drugs.
So we can probably just admit that this test have a high negative predictive value. If there are no reaction time or CT are normal, you can just exclude that there is a relevant amount of drug on board, but nothing more.
So, yeah, exactly. That is a very good conclusion on this issue. Yes, definitely, you're definitely true. Yeah, very good.
And this is something that is, let's say, probably again, we already replied because it's a question from Dr. Papatanasio. He's asking us, we have normal levels of APTT or thrombin time. Can we use this as an evidence that there is no relevant amount of drug on board?
Unfortunately, not. If the APTT is negative or normal, then I would say it is highly unlikely that the patient has taken dabigatran or that he is having active levels of dabigatran. But especially for the apixaban, which is marketed under the brand name Eliquis in Europe, we know that this drug does not influence the PT or PT ratio or APTT very much, saying that you can have normal APTT and PT values while the patient has taken the drug 5 to 6 hours ago.
Yeah.
So if you do not know which drug the patient has taken, it is hardly possible to derive from the standard coagulation lab that there is no active drug level in the patient.
So Dr. Huerta is asking, when will you use NOVO7 factor 7, recombinant activated factor 7A?
We would only use factor 7A in case we have no direct reversal agent, and in case the prothrombin complex concentrate is not effective. And so this would be some sort of a last resort treatment. And we would not use it as a first-line treatment. It would always be a secondary or ultima ratio treatment approach.
Okay, so we have another 4 questions, and then we will probably have to close the session. So very quickly, from Dr. Preda, if we say that the anti-10A activity is not correlated with the level of coagulation, why should we dose it? I think you didn't say this.
No, I didn't say this. Well, I'm very conservative with the use of factor 10A activities to calculate the risk of bleeding, because we know that, especially for the rivaroxaban, that patients in the approval studies who have bled had a wide variation of plasma levels of rivaroxaban. There were patients with very low levels, and there were patients with very high levels. So we cannot have the correlation that high levels have a higher risk of bleeding and lower levels having a very low risk of bleeding. So that's what I want to make sure with the measurement of a calibrated anti-10A activity prior to elective surgery is that the levels are as low as possible for this elective procedure. And this is also, on the one hand, it's a medical issue, but on the other hand, it is a legal issue as well. I want to have best preconditions for surgery that I can imagine.
And another interesting question is a patient with chronic heart failure. They are known to have a reduced kidney function. Is this something that we should consider whenever we deal with the half-life of the drugs?
Well, I'm almost sure that the degree of heart failure does not play a greater role for the elimination of the drug, but that what is always concomitant in these patients is that they have some degree of renal insufficiency. And this is what worries me in terms of anticoagulant treatment with NOACs. If you have this patient with severe heart failure, he is most likely to have some sort of renal compromise, and this will prolong the half-life of the NOACs, and therefore this will finally be the indication for giving these or for treating these patients with a renal dose of the NOACs, or if the renal insufficiency is going to deteriorate, then below a glomerular filtration rate of 15 mils per minute, which is roughly a creatinine between 2.5 and 3, then you have no more indication for the NOAC treatment. And for these patients, the drugs are not approved anymore.
And from Dr. Huert, if you have a patient that is under this drugs treatment due to atrial fibrillation and a high risk of stroke, what is the time that we should wait between the withdrawal of the drug and the surgery?
Well, very good question. In these patients with high risk of stroke, I would like to have the time as short as possible. That means if the patient has no renal compromise and is undergoing a minor procedure, you should stop the drug on the day before surgery. That would say the patient will take the drug on Monday morning, the last time to be operated on Tuesday morning. So you have a 24-hour interruption interval, and you can start the patient on the drug again at the latest on Wednesday morning. That means 24 hours after surgery. If it is a very, very minor procedure, you can restart the NOAC already on the evening of the procedure. That would be my recommendation to limit the risk of stroke with in this specific patient setting.
So we have this last question now, and it is: do you think there is any role for tranexamic acid with these bleeding patients under direct oral anticoagulants?
Well, there is no direct effect of tranexamic acid. I know at least one study that was investigating the effect of tranexamic acid in an animal model that did not find any positive response or result for the tranexamic acid. I would recommend giving tranexamic acid more as an adjunct to the stabilization of the clot rather than to expect a more direct effect on the anticoagulant. But yeah, that would be my expert opinion. There is no better evidence-based data on the efficacy of tranexamic acid in these situations.
So, thank you very much, Christian, and all the participants. I think we can now stop in the scheduled time this very interesting webinar. And so, thanks again.
Okay.
I have to leave. Okay. Bye.
Thank you very much, and have a good time and have a good evening. Thank you so much.
Thank you. Bye.
Okay, bye-bye.